Cathy, and my name is Laurent Brochard. I'm an intensivist in Toronto.
This is speech on my earphones. I just realized you could hear us.
Oh, sorry, someone else is. Yeah. And I've been asked to present a kind of introduction to mechanical ventilation. So I should say upfront that this talk is not for highly specialized people in mechanical ventilation. It's more an introduction about the main principle, the working principle, and how it could be used at the bedside, and how to avoid some mistakes. So apologies if you that some things are not going into enough details. And I'm going to start hopefully showing the full screen. Maybe Cathy, if you can confirm it's okay.
Sure.
Yeah, okay, thank you. So mechanical ventilation is the primary tool we use in the ICU. It's almost how we define intensive care, and it's both simple and complicated. Simple because it should be simple things to push air in and out the chest, but very complicated in reality because it has to be adapted to the specificities of the patient. And I would say this is our job to understand that and to try to deliver the best individualized mechanical ventilation. So I'm working with a number of companies from which I receive research grants for the first 3 or equipment for the last 4, which are my conflicts of interest. So I cannot discuss everything, but we'll try to get some time at the end for additional questions. And I will try to keep in mind the general working principles of mechanical ventilation and ventilators. We'll spend some time at discussing what we call respiratory mechanics, especially during volume control, because it's how you interpret the pressure and better understand your patient. And maybe one of the strong message I'd like to give is that one of the interests of mechanical ventilation is to better understand your patient. And if you miss that, you miss a lot about mechanical ventilation. We'll discuss briefly about volume versus pressure. We'll describe the expiration phase and the concept of auto-PEEP. And we'll spend some time about partial support or assisted ventilation. The terminology is not very precise in that field, which we use all the time and which are sometimes more complex than what we think. And that's why we will discuss a little bit about what monitoring during assisted breathing. So it's important to keep in mind that to work, ventilators need a high pressure source, and they deliver gas under pressure by controlling the flow, as I will show you. So the pressure source is usually the wall pressure or a pressurized tank of compressed gas. All the gas are compressible, and this is something relatively important, which when we measure how much volume we deliver, every time we increase the pressure, we increase also the volume because we compress the gas. So the ICU ventilators are using the wall pressure, but small portable ventilators use their own turbines to generate the pressure. So inside the ventilator, this high pressure source is controlled as a flow source by a precision valve, which is usually an electromagnetic valve like this one. You see the the drawing where there is an orifice which is, let's say, calibrated, and the opening of this orifice by moving a piston inside a small chamber under with an electromagnetic current is controlling how much flow is delivered to the patient. And these electromagnetic valves have really progressed in quality and precision over the years. And this is really very precise equipment within the ventilators. So this, it can be solenoid valve or other. I'm showing that because it's important to realize that what the ventilator is controlling is really the flow. The flow is the amount of gas per unit of time, so it can be expressed in liters per second or liter per minute, which is confusing because we tend to mix with the notion of minute ventilation. But in fact, it's the immediate amount of gas which is going to the patient per unit of time. And this is what is controlled by a ventilator, whether it's volume control, and we say volume control, but it's really flow control, or whether it's pressure control, because with pressure control, this valve is working all the time to control the flow to maintain the pressure measured at the outlet of the ventilator. So as I said, there are turbine ventilators which do not need to have a high pressure source. They usually use pressurized oxygen, but that's more for increasing the FiO2, not for the working principle of the ventilator. So these turbine ventilators classically have been used for non-invasive ventilation, the BiPAP ventilators, for transport ventilators. But because this technology of the turbines is getting better and better, they are now able to deliver relatively high pressure, very similar to the classical ICU ventilators working on the pressure wall. And you tend to see more and more of ICU ventilators now working with turbine. The interest is that, of course, you do not need to put to connect the ventilator to the wall. We usually do it for oxygen, but you could have another source of oxygen. So it has also it has some limitation, but it has advantage. In the future, we'll probably see more of these turbine ventilators in the ICU. An important point, and because it's often forgotten, is that if you use compressed gas from the wall, the gas will be very dry, will be almost no water content. And this is very dangerous for the epithelium of the airway and the alveoli. And we know that just a few, less than several hours of dry ventilation will create very quickly injury and very thick mucus and injury in the epithelium. So you need absolutely to provide airway humidification, and we have two systems. One is called the passive system. This is the classic filter, heat and moisture exchanging, which keep the humidity of the exhaled air and give it back at the next inspiration. It's not giving the maximum possible water content, but the passive filter working like a sponge work relatively well and can be used at least for short-term ventilation. If you want to have a really good humidification, heated humidifier are the best, but both techniques are not perfect, and they have downsides which may be important to know. One of the most important one is what we call the dead space, the circuit dead space, instrumental dead space. And for those who are not familiar with dead space, is the notion of recirculation, if you wish. The same gas is exhaled and then re-inhaled. So the exhaled gas is full of CO2. If you have a re-inhalation of this gas, it will be part of ventilation which is wasted and which will not clear CO2. So for that reason, for patients in whom we want to use relatively low tidal volumes, and we are at a time where low tidal volume is mostly the rule for most of the patients, decreasing the instrumental dead space is absolutely key. And that's one of the reasons, apart from providing good humidification, why heated humidifiers are chosen, because they don't add dead space to the circuit. What's the dead space is when it's both in the inspiration and expiration. So mechanical ventilators deliver flow, as you understand, which is in after a certain amount of time is volume, and they usually monitor the pressure resulting from the delivery of volume. So it's useful to spend a few minutes on understanding where does this pressure comes from and how do we explain this pressure. So why do we need pressure for ventilating the respiratory system, which is insufflating the chest? Pressure is force per surface area, and there are two main forces which oppose the entry of gas in the chest. And to counteract these forces, pressure is needed. So one force is the resistance to flow. The resistance is due to the tubings and, of course, to the internal airways. On a mechanical ventilator in an intubated patient, a large part of the resistance is the tube and the proximal airway. And the other force is, there are different terms, but it's the elastic recoil of the system, so the lung and the chest wall, which would tend to go back to their resting volume and which oppose elastic forces. So what makes pressure increase on the ventilator? The quantity of volume which is delivered, the resistance of the tubing and the airway, and it will be high in situations like asthma, obstructive airway, or a lot of secretions, and the elasticity of the lung, which will be decreased by situation decreasing lung volume like atelectasis, pneumothorax, fibrosis. And I will show you a bit later that the size of the open lung, of the aerated lung, is the most important component explaining the higher pressure. So to make it short, the smaller the lung, the higher the pressure for a given volume. And that's explained why the volumes are different from the same pressure in neonates, in infants, and in adults. And that will explain also why the pressure is higher in small lungs like ARDS lungs. And the chest will play a role which may vary among individuals. And you probably all know about abdominal compartment syndrome, for instance, where the pressure in the abdomen will have repercussion on the pressure in the chest. And just to remind you that the abdomen is part of what we call the chest wall. Okay, just for fun, I wanted to give you two lessons we learned from COVID-19. During COVID-19, everybody wanted to create new ventilators. You may remember this kind of panic where people in all over the world thought that there were not enough ventilators. And everywhere, engineers, a lot of smart people from and a lot of industrial companies, from vacuum cleaners to cars to simulators, decided to create new ventilators to provide to everybody. And just one word to say, no one worked. Okay, no one has been commercialized. So just to say, that's not that easy to bring these ventilators to the market. And the other thing we learned, which was again, interesting for this talk, is that again, because there was not enough ventilators, people tried to ventilate 2-3 patients with the same ventilator. And this turned out to be extremely complicated because one patient from the other has different respiratory mechanics, and the same output from the ventilator will be delivered differently in the 2 patients. And so there has been a number of publications, I just put 3 of them, trying to show how it could be possible with the different tricks to ventilate several patients with one ventilator, but that's really complicated. Okay, just to give you an overview of the difficulty of the exercise. So it's important to understand respiratory mechanics, and it will give you, as a clinician, information about your patients. The best way to measure respiratory mechanics is when you use volume control in passive ventilation. And I'm going to spend some minutes explaining how to interpret the pressure under volume control ventilation. So, as I mentioned, you have 2 kinds of forces and therefore 2 kinds of pressures. The resistance, which create the resistive pressure, and the compliance or the elastance. I know it's confusing. Compliance is volume over pressure. Elastance is pressure over volume. So if you think of resistance, it's intuitive to think resistance gives more pressure. In terms of elasticity, that would be like elastance. Elastance gives more pressure, whereas compliance gives more volume. So you have resistive and elastic pressure. So again, you can deliver a fixed volume set by the clinician. It's called volume control. You can also deliver a fixed pressure, and the mode would be called pressure control ventilation. There are many different types of, let's say, pressure targeted ventilation. We'll go through that quickly a bit later, but I will concentrate now on volume control ventilation. So as we say, the pressure results from volume, resistance, and elasticity. And this is what you see on the screen of the ventilator when you use volume control in a passive patient. By passive, I mean the patient is not breathing, so either deeply sedated or even paralyzed. You have at the top, the first waveform is the pressure measured at the, let's say, what we call the airway opening pressure. So at the Y piece, let's say, to simplify. And the second waveform is the flow, and the convention is to put the inspiratory flow as positive, the expiratory flow.
You are doing.
Sorry?
I think someone forgot to mute. So.
Okay, no problem. So the convention is to say the inspiratory flow is positive, the expiratory flow is negative, which is a pure convention because you could just reverse your transducer and have inspiration negative and expiration positive. This positive means that it goes from the ventilator to the patient, and this negative waveform means it goes back from the patient back to the ventilator. And what you see is a square flow ventilation. So remember, the servo valve, the opening will be constant, will be the same orifice during the whole insufflation. And the pressure will go to what we call the peak pressure, maximum pressure. So to understand what is creating this pressure, it's easy to add a small pause at the end of insufflation. It's like if you were taking a deep breath and then you stop without exhaling. So you have no more flow, but you still have the volume in your chest. And when I say it's a pulmonary function test, it's because it will separate the total pressure from the pure elastic pressure. The total pressure, remember, is resistance plus elastic pressure, Whereas when you pause, you don't have any more resistance, you don't have flow, and therefore you have only the elastic pressure. Therefore, when you do that, this pause, you have two pressure now. You have the peak pressure still, but you have the plateau pressure, which let's assume the valve closed almost immediately, and the plateau pressure is the same pressure, the same volume in the system, but without the resistive pressure. So this pulmonary function test allows you to separate the resistive component and the elastic component. And there are very simple ways to calculate what we call the resistance of your patient. And again, in many patients, it will be mostly the endotracheal tube and the proximal airway, and the elastance of your patient, or the compliance of your patient. You could imagine that you have the two patients with the same peak pressure. That would be the example of one patient with essentially resistive pressure. So when you do the plateau, and sometimes you may need to have a slightly longer plateau, you will see a huge drop in the pressure. And it will tell you that most of the pressure is what we call dissipated against the tube and the proximal airway. And the pressure you will measure here is only the elastic pressure due to the volume entered into the chest. And I will again re-emphasize that, but this plateau pressure is the key pressure for the risk of ventilation. So by contrast, a patient, let's say, with normal resistance, most of the pressure will be related to the elastic pressure, and this will indicate a high elastance, or at the opposite, a low compliance. And we look at this delta pressure from plateau to PEEP, and we are concerned when it's higher than 15 centimeters of water. We call it the driving pressure. And in ARDS, it has been found that driving pressure going above 15 centimeters of water is clearly associated with higher risk of mortality, everything else being adjusted. And it has been shown that this is the most sensitive parameter to detect the risk of ventilation, which we call the ventilator-induced lung injury. So again, very practical aspect of having this plateau pressure on your ventilator is to measure the driving pressure and to measure the plateau pressure. So why measuring the plateau pressure? Because this is the pressure in the alveoli of your patients. So this pause at the end of insufflation allows also to measure the alveolar pressure, which is again the pressure which matters for ventilator-induced lung injury, but also for the hemodynamic effect of ventilations. The higher the plateau pressure, the higher will be the exposure of the pulmonary circulation to high pressure, and the higher will be the likelihood of increased right ventricular afterload and possible right ventricular failure. So plateau and driving pressure are two essential components of monitoring patients under volume control ventilation. And again, the recommendation is for plateau pressure not higher than 30 centimeters of water. And why 30? Because this is approximately the pressure at which you reach your total lung capacity. So every time you go higher than that, you're certain that you are over distending at least some part of the lung. Just a caveat, and I won't spend time on that, but we are talking of the alveolar pressure, which is measured by the plateau pressure, and it reflects the lung distension plus the chest wall. And the chest wall plays a role in this pressure, which is usually around 20-25% of this pressure. But in some patients, this pressure may be the pressure generated by the chest wall may be much higher. And I mentioned, for instance, abdominal compartment syndrome, or the obesity, which is the situation where you don't have a stiff chest wall, but you have a very high load because of the abdominal content and the weight of the chest wall itself. And therefore, your pressure, your alveolar pressure may be influenced by distension of the lung, but also the chest wall, which by itself is not at risk for the lung. What is at risk for the lung is the distension. And therefore, in those patients where the chest wall plays a role, it may be acceptable to have higher plateau pressure than usual because it's not reflecting the distension of the lung. The technique to measure it precisely is the esophageal pressure, which is a quite accurate measurement of the pleural pressure with, again, a number of limitations because the pleural pressure is not uniform. There is a gradient from the ventral part to the dorsal part. So let's spend a few minutes to make sure that everybody understands the concept of compliance. So compliance has been traditionally used to measure the severity of the lung injury under mechanical ventilation. And the compliance is in fact the ratio between the volume you delivered and the pressure observed. So let's take an example of patients where you deliver 500 ml of pressure. There is no PEEP, just for the sake of the discussion. And at the end of inspiration, the plateau is 10 centimeters of water. So it means that the compliance of these patients is 500 ml divided by 10, which is 50 ml per centimeter of water, which, let's say, in an adult patient in the ICU supine would be a reasonably normal value, even if it's not completely normal. But remember, when you deliver the 500 ml, it goes everywhere into the lung. It's separated into the two lungs and in multiple places in the lung. But let's imagine the same patient. You deliver the same tidal volume, but now you have selective intubation in the right side. So the same tidal volume, the same patient, but delivered only in one side, will give twice your plateau pressure. Instead of 10, you will have 20 centimeters of water, which means that your new compliance will be half of the preceding compliance. So 500 divided by 20, it will be 25 milliliters per centimeters of water. So this very simple example illustrates why compliance is mostly a marker of the size of the lung. And if you want, you could think of people with different size, different heights. And in fact, the compliance normalized to the predicted body weight, let's say, which reflect the size, is about 1 milliliter per centimeter of water per kilogram of predicted body weight. So a neonate or a premature neonate, only 1 kilo will have a compliance of 1. Patients of 70 kilo will have a compliance of 70, just to give you a rough idea. So to illustrate how interpreting the pressure on mechanical ventilation will give you information about your patient. And this was very nicely illustrated in ARDS, where the CT scan allowed Luciano Gattinoni and his group to make fundamental observation about the explanation about the drop in compliance, and he showed it was very well correlated with the residual inflated lung, the aerated lung, if you wish. So what we are measuring with pressure on the vents are something related to the size of the lung. Okay, conclusion of this first part, the pressure at risk for the patient is the elastic pressure, and the higher the elastic pressure, plateau and driving pressure, the smaller is a ventilated lung. We have recommendations saying plateau pressure higher than 30 or driving pressure higher than 15 expose the lung to high risk of injury and impose strain on the right ventricle. Lower pressures are safer, but that doesn't mean that we know exactly how low we can go. And this high pressure, when observed, may impose to reduce tidal volume and PEEP. Okay, let's move to, I spend a lot of time with volume control, to volume versus pressure control. So how does it work on a ventilator when you use a pressure controlled mode or a pressure targeted mode? And there are many on ventilators. It's with different names, pressure control, BiPAP, pressure support, APRV, etc. Very different modalities. So it's work again from the ventilator by controlling the flow, but targeting a pressure measured at the outlet. So it's a kind of closed loop system in the ventilator, and you will see the flow decelerating until the pressure is reached and maintained, and the pressure breaths, the pressure targeted breaths, will be delivered with something which looks a little bit like a square pressure, but in reality is never square because of this regulation. The end of the breath is either time in the classical pressure control ventilation, like volume control ventilation, which means after 0.8 seconds, the ventilator will stop. Or it can be flow, for instance, a certain level of flow during pressure support ventilation. We'll see that later. So are there fundamental differences between volume and pressure ventilation? So quick answer is yes and no. Yes, because as you have seen, what's going into the lung is delivered differently. It's delivered with a relatively constant pressure in pressure control, and therefore the flow is decelerating. Whereas in volume control, the flow is constant and the pressure is accelerating or increasing. But at the end of the breath, if you have delivered a certain amount of volume, and volume is the integration, the integral of flow, and if the integral of flow is the same in the two situations, in the lung of the patient, you will reach the same plateau pressure. So it may be different for some patients having the two different types of insufflation, but for many and most situations, I would say it doesn't make a big difference. The difference are essentially when patients are triggering the vent and breathing during assisted ventilation, where pressure targeted modes offer much more flexibility to the patient because the flow is not controlled. It's important to realize that when you use pressure control, any change in respiratory mechanics, or we say impedance on the respiratory system, will modify the volume delivered. So, for instance, in this bench example, you have an increased elastance or decreased compliance, and for the same pressure, the volume delivered will go down. So for this reason, you also have on ventilators a number of modes which are pressure targeted and volume regulated. So like, volume targeted, pressure regulated volume control, auto flow, you have on almost every ventilator, which adapt the level of pressure for a certain volume prescribed by the clinician. It makes sense to adapt to respiratory mechanics. It is also used during the assisted ventilation, which we'll describe briefly later. And in my opinion, it does not make sense in the same way, because the clinician has to decide what is the good tidal volume for the patient, which is really very difficult to know a priori in assisted ventilation. Okay, a brief discussion about the expiratory phase. So expiration is supposed to be passive, which, and I represented in red here, the alveolar pressure. Remember, it goes, the maximum alveolar pressure is your plateau. And as you can see from this drawing, the alveolar pressure is lower than the airway pressure during expiration, but it's higher than the airway pressure during expiration. So the pressure you see on the vent at expiration is below the pressure inside the lung. It needs a certain time to exhale. I won't go into complicated discussion, but the exhalation, and you can see that on the waveform on your ventilator, is an exponential decay. And when you don't see an exponential, it means that there is something wrong, and usually that the patient is breathing during the expiratory phase. And this exponential decay has a time constant, which is the product of resistance and compliance. So again, the same respiratory mechanics discussion. So the higher the resistance, the higher the compliance, the lower the elastance, the longer it takes to expire. And if you don't have enough time, if you as a clinician, you don't set enough expiratory time, your expiratory flow may be interrupted before the end of expiration. So you see on this figure, the flow has been shown here as negative during inspiration, positive during expiration. Remember, it's just a pure convention. And you see that the expiratory flow curve is interrupted by the next breath before it goes to zero. So if you see that, you know that there is still positive alveolar pressure, despite the fact that your airway pressure is zero. So this is called dynamic hyperinflation, and this is causing what we call auto-PEEP or intrinsic PEEP. I'll just show you a spectacular example. On the left, you have a patient with severe COPD. You can see the curve of the flow with this interruption at the end of expiration. And you see the airway pressure, the peak is going to 35. The end expiratory pressure is strictly zero. But when you interrupt the flow at the end of expiration, then you equilibrate the pressure in the alveoli with the airway opening pressure. And you see in this example, the huge intrinsic PEEP of this patient was 15 centimeters of water, and entirely explaining that this patient had a poor, low blood pressure, low cardiac output, and low urine output. So purely mechanical ventilation driven by dynamic hyperinflation. So important to recognize by monitoring the flow, because as you can see, you will not see it on the airway pressure curve. It's a hidden pressure inside the lung. So auto-PEEP, very briefly, is more frequent in patients with long time constant like COPD, emphysema, asthma. It has the same hemodynamic consequences as external PEEP or risk of barotrauma. It's dependent on the amount of tidal volume and minute ventilation. Please remember that. So every time you have auto-PEEP, the most efficient way to reduce it is to reduce tidal volume and minute ventilation. It may be reduced by longer expiratory time, but decreasing ventilation is more efficient. And there is, you may have this notion that having an external PEEP is useful for intrinsic PEEP. I would say no and yes. No, it's not useful during passive ventilation because you won't help to expire more, but it's very useful during assisted ventilation when the patient is actively breathing. You see an example of a patient with pressure support ventilation. And if you look at the number 4 waveform, the esophageal pressure, you see for the same pressure support, when you add a PEEP of 10 in these patients who had intrinsic PEEP, you decrease the work of breathing of the patient. So useful for assisted ventilation, not so much for passive ventilation. So I have just one slide about PEEP. PEEP is really important, but I have no time to go through everything. You see that PEEP can be indicated for intrinsic PEEP or airway closure. The most frequent reason why we use PEEP is to either recruit the lung, so we call it alveolar recruitment, or to prevent or treat atelectasis, which are very frequent during ARDS also. That's one of the reasons why we use PEEP. It can be useful in obesity. I mentioned this high load imposed by the abdomen and the chest wall. It has also benefits in heart failure. So there are many indications for PEEP, and unfortunately, I won't have time today to go into this different indication and different titrations. So I'd like to finish by two parts, which is about assisted ventilation and the partial support. And I apologize because the terminology here is very confusing. So people sometimes think that assisted ventilation is every form of ventilation, and other people say it's when the patient is triggering and the spontaneous breathing is assisted. So we could also discuss partial ventilatory support. Again, be careful when you think of what we are talking. But the key point is to think that the pressure in the chest may be very different, even if the pressure on the airway are the same, because there is another source of pressure moving the gas, which is the respiratory muscle contraction. So to be very schematic, you could have a situation on the left where it's complete support by the ventilator. There is no muscular pressure from the patient. On the right, the opposite, it's purely spontaneous ventilation. There is nothing from the vent. And partial support is everything is between, where you have both the ventilator and the patient working together. And this raises the issue of how much support should we give to the patients, and is the patient and the ventilator, are the patient and the ventilator well synchronized together? So just when we measure, these are two patients on pressure support ventilation. You have the flow at the top, the pressure is the second one, and then the esophageal pressure. When you measure the esophageal pressure, most of the time you see a negative deflection, which is what we see during spontaneous breathing. So in most situations, if you think at intrathoracic pressure during assisted ventilation, the pressure in the chest may be similar to spontaneous breathing activity. So there are different modes of purely assisted ventilation without any mandatory breath. There is a relatively complex mode, which I won't detail today, like neurally adjusted ventilation, which is NAVA, or proportional assist ventilation, or PAF+. These two modes act on the principle of measuring what the patient is doing and giving pressure exactly in proportion of patient's effort. So that's why we call them proportional modes. They have a number of physiological advantages, which are, I think, interesting, but they are more complex to use than the classical pressure support. And the use of this mode is relatively rare, even worldwide, because it's very difficult to show major clinical outcomes, even if there are a number of beneficial physiological outcomes. So the most frequently used mode is pressure support ventilation, where you just set the pressure and you let the patient breathe on his or her own. And it looks very simple. It is relatively simple, but I will try to show you that it has also a number of drawbacks and limitations, and it would be good that more people be aware of that. So just a very quick reminder of how mechanical modes, ventilation modes work. On the ventilator, you have a variable which is how the ventilation starts, which is the trigger variable. You have a variable which is what is sustained during inspiration, limit variable, and how inspiration ends, which is a cycling variable. So and then you have how it goes back during expiration. And for instance, if you look at pressure support ventilation, what triggers every breath is a signal from the patient, which can be flow or pressure. What is the limit variable or sustained during inspiration is pressure, and the cycle variable is flow. So why I am showing that? For two reasons. One is that if you think of pressure control ventilation, you know that patient can also trigger breath during pressure control ventilation. And if you think at pressure control ventilation, when patient trigger, the trigger will be the same. The limit variable would be exactly the same. And the only difference would be the cycling, which on pressure control would be time. So just for you as a clinician, remember that same pressure on pressure support and pressure control will give very, very similar ventilation. So it's not because the patient is on pressure support versus pressure control that is working more or less. It's very similar. And second important point, this cycling variable is really important. It's proportional to the peak flow. And that's a limitation of pressure support because the peak flow depends on how much pressure you give. And the higher the pressure, the higher will be the peak flow, but also the later will be the peak flow. We will see that. So what's a big limitation of pressure support is that when you increase pressure support, you usually increase also the insufflation time. I will show you that. So it's a very nice mode, and people have been happy using it clinically. There have been a number of studies. This is one of the first study we did a number of years ago, and you see tracings of physiological signals like muscle activity, sternocleidomastoid muscle, diaphragm, transdiaphragmatic pressure without or with pressure support. You see two patients. It's usually the adaptation is very rapid, like in 1 or 2 minutes, and it's just one main simple adjustment. We also show that it has a strong effect on the work of breathing. So if you reduce the work of breathing, you also reduce the oxygen consumption of the respiratory muscle, what we call the oxygen cost of breathing. So and again, a last example, if you look here on the right, this is pressure support 6, pressure support 2, and the third waveform is the esophageal pressure. You see it's almost directly proportional to your pressure support. And the last signal is the electrical activity of the diaphragm. So you modulate the activity of the respiratory muscle of your patient. And this figure was a comparison with ECMO and the gas flow, which has the same effect because it washes out the CO2. So it looks very nice. You increase pressure support, you increase the volume delivered to the patient, you decrease the work of breathing of your patient, and usually you see a decrease in respiratory rate, which is a bit misleading because, as I told you, it's not entirely natural. It's in part related to the way pressure support works. It increases the duration of insufflation. So the apparent respiratory rate decrease can be misleading, and I will show you some examples. The problem with pressure support, which is very frequent, is that you don't know where to stop. And if you give too much pressure support, you will give more volume than desired by the patient, so you will create some hyperinflation. And you may reach a situation where you no more decrease the work of breathing, so the patient is only doing a very little effort to trigger the vent, and it has been shown experimentally this creates the condition of diaphragm disuse atrophy. And this is the situation where you'll see most of the asynchrony, like the ineffective efforts and the apneas on the ventilator. And every time you have a patient becoming apneic on the ventilator, it means two things. First, the patient is trying to sleep, because you become apneic only when you sleep, not when you're awake. And second, it means that you're giving too much pressure support. And as I told you, the reason for this desynchrony, there are many explanations, but is that by increasing pressure support and giving more volume, remember you increase the peak flow comes later, and then the insufflation times goes up. At the same time, the patient's inspiratory time goes down. Patient is doing less and less effort. And the distance between what the patient is doing and what the ventilator is giving makes insufflation delivered for a large part during the neural expiratory time of the patient. Okay? The insufflation becomes so long that it comes into the patient's inspiration. And when the patient wants to take the next inspiration, is still hyperinflated. So this creates this desynchrony. By desynchrony, we mean that the patient and the ventilator are not working together at the same time. So this is an example where you would have a good synchrony. The esophageal pressure and the airway pressure are relatively synchronous, but it's sometimes hard to detect because you don't have the esophageal pressure, and you need to rely on the observation of airway pressure and flow curves over time to detect this asynchrony. So just to give you an example, this is a patient who looks from far away, being very regular. You see the pressure support breath, the flow tracing, the volume. But if you look carefully, you see these small changes on the flow and the pressure. And in these patients, we had a monitoring of the diaphragm activity. And you see that twice during this short period of 3 breaths, you have what we call ineffective efforts, which mean the patient is doing the same effort than when triggering the vent, but is still hyperinflated, cannot trigger the vent, and you have a lot of missed efforts. So it's important to understand that because for 2 reasons. First is that it means you are delivering too much ventilation to this patient. And second, the respiratory rate of the patient is not 18 as indicated here, but is maybe more around 35 or 36. And this is a natural respiratory rate of your patient. You have a number of patients with high rate who are not in distress at all. And if you go down on the pressure support, because this indicates you give too much pressure support, the respiratory rate will go up, and it should not be taken as a sign that the patient is going into distress. And I think this is the main reason why there is a very, very strong association between ineffective efforts and high duration of ventilation. It's because people are reacting inadequately to the change in respiratory rate and are delivering too much ventilation. So the way it works with pressure support, and maybe I can skip that. Oh, no, sorry. Is that if you want, the patient has a desired tidal volume, and over a certain range of pressure, so on the curve on the left will show in blue the tidal volume, you may change the pressure support, but do not have major changes in tidal volume. The patient will keep almost the same tidal volume. And this is the muscular pressure. But above a certain threshold, you will see that the patient will give more, much more volume with more pressure support. You won't decrease much the muscular pressure, and you will go into asynchrony, excessive ventilation, etc. So there are a number of parameters you can monitor. The respiratory rate, and for instance, it has been shown that when your respiratory rate is below 20 or 18, it's very likely that you are hyper assisting your patient. And you can also look at one thing which is easy to measure on the ventilator, the P01 or occlusion pressure, because it's now available on most ventilators. And a P01 below 1 centimeter of water always indicate that the patient is hyperventilated. So I think I will stop there because we are almost at time. Happy to address any more questions, and you can also write me by email. So if we have a few minutes, I will happy to answer questions.
Feel
I
free
think I
to
think
use.
it's almost 1 hour, so I don't know if we wait for more questions or we stop there.
Okay, so thank you very much, Dr. Brochard, for the insightful and comprehensive presentation this morning. I'm sure we all learned something new from you today. As a reminder to everyone, the survey link to this webinar is posted in the chat room. So you're welcome to fill out that survey. And we'll be sharing the recording sometime later today or later next week. The next adaptive platform trial webinar will be scheduled and is scheduled on January 29th. Dr. Steve Webb will be presenting to us what's a platform trial. We thank everyone for your time.
And
Yes.
Cathy, just to say, I'm available by email for any thoughts after this talk and any questions you have. Always happy to chat. Thank you very much.
Thank you. Thank you, everyone's time.